Hi everyone, good day. This is Doc Fon, and I'm also one of your lecturer for Clinical Chemistry Laboratory part. Our discussion for today will be our last topic before we will have our prelim examination. So let's begin. For today, we will be discussing the enzymes of clinical significance. Actually, this is a continuation of all the different enzymes that you have already discussed. So for today, we will be discussing about your CK and your LD. So first, we will be discussing about your creatinine kinase followed by your lactate dehydrogenase. For your CK, we will be discussing about different properties, tissue source, the isoenzyme, the diagnostic significance, as well as the assays and the sources of error for your CK. So your CK has a enzyme nomenclature of EC2732, ATP, creatine, and phosphotransferase. From the name itself, creatine phosphotransferase, meaning it has something to do with the transfer of your phosphate group. From the name itself, kinase, basta anything that but any enzyme that has the word kinase itself, it has something to do with the transfer of your phosphate group. Remember, in your biochemistry, in your glycolysis, what is the rate-limiting enzyme for your glycolysis? It is your phosphofructokinase. So, it also ends with the word kinase kasi nga, the action of your PFK is to simply to transfer the phosphate group to your fructose. That is why, from your fructose 6-phosphate, the action of your phosphofructokinase is to add another group of phosphate, making now a fructose 1,6-biphosphonate. So the same with your creatine kinase, it has also something to do. Anything that ends with kinase, its function is also to transfer your phosphate group. So basically, your CK is associated with ATP regeneration in contractile or transport system, which is predominant in your muscle cells. Remember that every contraction cycle of your muscle results in creatine phosphate use with the production of ATP, because you really need a constant supply of your ATP. So in your muscles, because this is contracting, you need a constant source of your energy, and this will be with the help of your CK, you will have the enough constant amount of ATP for your muscles to work. So your CK is approximately 82 kilodalton. It involves in the storage of your high energy creatine phosphate, and levels vary with muscle mass, meaning for gender, males have more muscle mass compared to female patient because your female has more fats than muscle mass. Your race, your degree of physical conditioning for those who are more into sports, who are physically active, who are exercising, they tend to have more muscle mass compared to normal individual. For age, adult, in terms of mga aged patient, they are having lesser muscle mass compared to age mga around 20 to 40 years old. So this is now the reaction of your creatine kinase. CK, creatine kinase, something to do with transfer of phosphate. So creatine plus the source of your phosphate here. So what happens? Your CK will transfer one phosphate group of your ATP towards your creatine, making it a creatine phosphate plus your ADP, because you transfer one phosphate here towards your creatine. So what are the tissue sources for your CK? So the highest activity will be skeletal muscles, heart muscles, and brain tissue, because it has something to do with muscle activity, muscle contraction. So we expect that majority of your CK will be located into your skeletal muscles, heart muscle, as well as your brain tissue. But this could also be located in other organs of the body, such as in your bladder, placenta, GI, and etc. So in terms of its isoenzymes, when we say isoenzymes, meaning iso, mean same enzyme for CK, but they differ only with its location. CK also occurs as a dimer with two subunits. So, may two subunits siya, M and your B. So, your CK's subunits, M and B, we have CKMM, which is your muscle type. We have your CKMB, which is your hybrid type. And we have your CKBB, which is your brain type. Again, isoenzyme, same activity, same enzyme activity that exists in different proportions in different tissues. So, when your CK isoenzymes is being processed in an electrophoresis, what happens is that your CKBB will migrate fastest towards your anode. Here, your CKBB migrates towards your anode, while CKMB follows your CKBB, then followed by your CKMM. So among the three, the fastest is your CKBB, followed by MB, and the slowest mobility is your CKMM. So your CKBB is also termed as your CK1, CKMB, CK2, CKMM, which is also your CK3. So technically, they're just being alphabetized. So, BB siyang nauna sa letter, followed by MB, followed by your MM. But Doc, what are these other two, macro CK and macro MI? Later on, we will discuss about these other CK isoenzymes. But for the discussion, what is more important is actually your CKBB, MB, and your MM. So that for the different isoenzyme, your CKMM is actually located in your heart and your skeletal muscles. And these are the conditions that is associated with your CKMM. As what you can see, since it's in the heart, that's why it is more conditions are related are the following: MI, skeletal muscle, muscular dystrophy, polymyositis, and etc. So basically, since it involves your muscle, your CK involves your muscle, that is why majority of your conditions have something to do with your muscle tissue. How about your CKMB? Same with your CKMM. It is also located in your heart and your skeletal muscles. And also, other conditions can also detect the MI, myocardial injury, ischemia, angina, etc. So majority also have something to do with muscular disorder. How about your CKBB? It also can be located in your brain, bladder, lung, prostate, and other tissues. So majority of these disorders will be your central nervous system shock, anoxic encephalopathy, cerebrovascular accident, seizure. Remember, BB, this is more of the brain. That is why the conditions here are mostly CNS, mostly involves your brain. So in terms of their quantities, your CKBB is present in small quantities, detectable depending on the method. Most techniques cannot detect this in normal serum. So in short, your CKBB has only very small quantities. CKMB, it is undetectable to trace, while your CKMM is the major isoenzyme in sera of healthy people. So among the three, what is normally found in an individual, in a normal, healthy individual, is your CKMM. That is why anything that will tend to increase your CKMB or CKBB, then there could be an disorder that is associated with the increase of it. So your CKMM, major isoenzyme in a normal sera, around 94 to 100%, and skeletal muscle. Your skeletal muscle is mostly CKMM, small amounts of your CKMB. Your heart muscle is mostly CKMM and 20% CKMB. For your CKBB, only small quantity that can be found inside your body. Short half-life is only around 1 to 5 hours. It is elevated in CNS damage, tumors, childbirth, presence of macro CK. May be a useful TM increased in carcinoma of various organs or untreated prostatic CA and other adenocarcinoma. How about the two other bonds that we have seen in your electrophoresis? Based on this diagram in your electrophoresis of your creatine isoenzymes, we can also locate two other unusual bonds. We see there is a Ckmi. This Mi does not stand for myocardial infarction, it's different. This is Ckmi, and there is also macro Ck. Your macro Ck is located between your MM and your MB, while your Mi is the slowest among the 5 isoenzymes. So let's talk about your macro Ck. So as I said, your macro Ck is located between the MM and your MB. It is largely comprised of CKBB complex with your immunoglobulins, CKMM plus your LP. So it's around 0.8 to 1.6%. And in terms of, it is actually related with age and sex related in terms of the detection of your macro Ck. Some age or some gender biases that will actually detect the level of your macro Ck. So it is largely IgG, but also some textbook would say that IgA has also been described. Not only IgG, but also IgA. In terms of its clinical significance, researchers found out that there's still no clinical significance of detecting your macro Ck. How about your Ckmi? Again, your Ckmi, among the 5 isoenzymes, it is the slowest or more near to your cathode. Your Ckmi is bound to exterior surface of the inner mitochondrial membranes of the muscle, brain, and liver. To be detected in serum, there must be extensive tissue damage. It is an indicator of severe illness such as malignant tumor, cardiac abnormalities. So, your Ckmi actually cannot identify a specific certain condition. However, when you are able to detect Ckmi, that would only mean that it is already severe. We cannot specify what type of condition, but it will always mean that the condition is already severe when you can detect your Ckmi. Now let's proceed with the diagnostic significance of these isoenzymes of your Ck. So it is elevated in the following disorders: cardiac muscle, MI, skeletal muscle, rhabdomyolysis, and your Duchenne type muscular dystrophy. So in short, since Ck is majority of your Ck is located in the muscular tissue, that is why the common disorders that can be associated with your Ck has also something to do with the different muscular disorder: cardiac muscle, myocardial infarction, skeletal muscle, rhabdomyolysis, or your Duchenne type muscular dystrophy. What is a Duchenne type muscular dystrophy? This is actually a inherited disorder wherein there is weakness of the muscle due to the lack of what protein? Your dystrophin. So that's why Duchenne type muscular dystrophin. How about it's also can be associated with your CNS disorders. Remember your CKBB? That is why you're common in your cerebrovascular accident or your stroke, your seizure, your nerve degeneration, your CNS shock. Damage to your blood-brain barrier must occur for enzyme to be detected in peripheral circulation. Elevated Ck levels can also be associated with hypothyroidism, malignant hyperplexia, Reyes syndrome, mild to strenuous physical activity, IM injections. Your Ck levels and your Ck progesterone ratio can also be helpful for ectopic pregnancies. Your total Ck levels can also be helpful for any infection related to Vibrio vulnificus. So your Vibrio vulnificus will tend to have a manifestation of severe watery diarrhea. Other tests, we have your ischemic heart. Other disorder, we have your ischemic heart damage. Myocardium is the only tissue from which CKMB enters into the serum in significant quantities. greater than 6% of your total CK is actually indicative of your ischemic heart damage. So your CKMB is more specific towards your ischemic heart disease. But what is more specific when patient is having myocardial infarction? Is it your CKMB? No, it is your troponin I and your troponin T. Remember your trop I and trop T? Your trop I and your trop T are more specific and more sensitive for your myocardial damage. These are actually proteins that are released in your bloodstream earlier and persist longer than your CK and other isoenzymes of your CKMB. So in short, in patients with having with myocardial infarction or acute myocardial infarction, patient would tend to have increased level of your trop I and trop T, and these are the most specific and sensitive marker for that. But in terms of enzyme, CKMB can also be helpful because it is the only tissue that can enter the serum in significant quantities. So that's why it's not just trop I or trop T ang nire-request namin. We could correlate it with other enzymes such as your CKMB, specifically your CKMB. We could also correlate it with the other enzymes. What else? We have your AST. What else? We have your LDH. So in short, there's no other enzymes that can actually specifically determines whether this patient is having MI, unlike your protein markers, which is your trop I and trop T, which is more specific to your myocardial infarction. So in short, the following enzymes, CK, AST, and LDH, it must be correlated. These three enzymes must be correlated. So your myocardial infarction, it is caused by your ischemia. It is more specific diagnostic if tested in conjunction with your trop and or lactate dehydrogenase isoenzymes. That's why ito yung sinasabi ko. We cannot just specify one test, but we have to correlate it with the other tests. You have to correlate the levels of your CK, the levels of your LDH, the levels of your AST, and the levels of your trop I. It must be a correlation, and this test must also be correlated to the clinical manifestation of the patient. We do not or solely rely our diagnosis to the laboratory result. But again, you have to go back to the patient. What are the symptoms of the patient? What is the physical examination of the patient? And with the help of the test, now we can be able to correctly diagnose our patient and correctly manage the patient. So for your CK will tend to rise within 4 to 8 hours after the onset. Remember that your CK with myocardial infarction, it will immediately rise around 4 to 8 hours after the onset, and it will peak around 12 to 24 hours and return to normal within 2 to 3 days. So it will rise immediately and back to normal around 3 days. So in terms of the assays for your enzyme activity, how do we identify these enzymes, isoenzyme? It's through your isoenzyme separation. Remember your electrophoresis? So this is now your electrophoresis we discussed a while ago. It is the reference method. The separation of atypical bonds as well as your detection of your AK. So hemolyzed samples should be identified. Cathodal to CKMM, interference in chemical or immuno inhibition methods, falsely high CK or CKMV value. But prevention is better, right? That's why we have to really identify all of these isoenzyme. So isoenzyme separation, we have your ion exchange chromatography. With good technique, may be more precise. Your RIA or radio immunoassay, it's measure the concentration rather than the activity. It may detect inactive CKMB. Another test, we have your immuno inhibition. Your immuno inhibition, another isoenzyme separation technique is your immuno inhibition. It uses your anti-M. You use your immunoglobulins, physically an anti-M that will inhibit the M activity. Actually, when sa laboratory, when we use our kit for CK, this is actually the test. This is actually the assay that majority of the kit actually utilizes your immuno inhibition. Anti-M inhibits the M activity. So what is the rationale between the inhibition of your M is actually the CK activity is measured before and after the inhibition. Residual activity is multiplied by 2 to account for MB, which is 50% inhibited. So ganito yan guys. You have an anti-M. Remember the isoenzyme, meron tayong MM, MB, and BB. So in short, you inhibit your anti-M. So you inhibit the anti-M, so what is now being detected is your BB. Since your BB is negligible or very slow, so the activity of inhibition is actually equivalent to the level of your CKMB, and you multiply that 2. So in short, you're able to detect the level of your CKMB. Again, I will repeat that when we reach the kit insert. So the kit insert na ating i-discuss later on. So what are the different assays for the enzyme activity? We have your coupled enzyme method, change in your absorbance at 340 nanometer. Actually, it depends. Marami namang, it could be 340, 357, depending on the kit. It's not specifically 340 nanometer, but what is commonly used is your 340 nanometer. The wavelength sa ating spectro na machine. So that there are two tests that we could, use. We have your Tanzer-Gilbert, we have your Oliver-Rosalsky. Your Tanzer-Gilbert is the forward reaction, while your Oliver-Rosalsky is the reverse reaction. But what is most common is actually your Oliver-Rosalsky, the backward reaction. It is 2 to 6 times faster than the forward, and there is less interference. That is why your Oliver-Rosalsky is most commonly used. So for Tanzer-Gilbert method, the pH or the optimum pH for this test is actually basic, around 9. So for the reaction, it uses the 3 different enzymes, your creatine kinase, your phosphokinase, and your lactate dehydrogenase. So your creatine and your ATP by the action of your CK kinase. Basta anything that has kinase, something to do with transfer of phosphate. You transfer the phosphate from your ATP towards your creatine, it will result into creatine phosphate, and what is left is now your ADP. This ADP added to your phosphoenol pyruvate by the action of your pyruvate kinase. Another one, pyruvate kinase. You transfer the phosphate group here, phosphoenol pyruvate, to the ADP. Ang nangyari, nagiging ATP, at ang natitira is nagiging pyruvate. And then you get this pyruvate, you add it with your reduced nicotinamide adenine and the hydrogen. By the action of your lactate dehydrogenase, it will convert your pyruvate to your lactate and reduce your oxidizes your NADH towards nicotinamide, oxidized nicotinamide adenine dinucleotide. Remember your LD, we will discuss actually LD later on. Actually, your LD has two effects, changing your pyruvate into lactate or lactate to pyruvate, and changing your oxidizing or reducing your NAD. If it is already reduced, it will oxidize your NAD, or it will actually from oxidize to reduce. So interconversion. That's why dalawang arrow yan. You can do this reaction or in that reaction, forward or backward reaction. So this is basically your Tanzer-Gilbert method. How about your Oliver-Rosalsky method? It is also basic, using the pH of 6.8. So your creatine phosphate plus your ADP by the action of your CK creatine phosphate. Transfer of your phosphate group towards your ADP. Kaya ang natitira, nagiging creatine plus, actually this is wrong, this is creatine and your plus ATP. Mali ito guys ha, this is wrong. This is actually, mali ang sinabi ko, this is acidic rather than basic, sorry. This is acidic. So your creatine phosphate plus ADP, the action of your CK, transfer of phosphate from your creatine phosphate towards your ADP, ang nangyayari, nagiging creatine plus ATP, hindi ADP, this is wrong guys ha, creatine plus ATP. Then the ATP plus your glucose by the action of your Hexokinase, again, hexokinase, kinase again, it ends with phosphate group. Hexose refers to the glucose. So transfer of phosphate towards your glucose. So you transfer one phosphate towards your glucose, ang nangyayari, nagiging ADP na lang at nagiging glucose 6-phosphate. Your glucose 6-phosphate will be used and added by your oxidized nicotinamide adenine dinucleotide phosphate. By the action of your G6PD, it becomes your 6-phosphoglucokinate plus your reduced nicotinamide adenine dinucleotide phosphate. So this is your Oliver-Rosalsky, and this is the most common method that is being employed. CK activity is unstable. It is inactivated because of oxidation of your sulfhydryl groups. Can be partially reversed by the addition of your sulfhydryl compound. So in order to reverse this inactivation by your sulfhydryl groups, you will add your NAC or your N-acetylcysteine, your mercaptoethanol, your thioglycerol, and your dithiotritol. So what are the different enzymes as the sources of assay error for your CK? Hemolyzed samples, falsely elevated CK activity because of? Why do you think that there will be a hemolyzed sample from an elevated CK activity? It can lead to a falsely elevated CK when you have a hemolyzed sample because of your CK could also be detected in your red blood cells. Your serum should be stored in a dark place. Activity can be restored after storage in the dark at 4 degrees Celsius for 7 days or at negative 20 degrees Celsius for 1 month when the assay is conducted using a sulfhydryl activator. Your muscle activity prior to blood collection also affects your activity. That's why it is really important to know the activity or the muscle status of your patient, whether the patient is active, because if the patient is active, the CK baseline will tend to be more increased. Unlike for those patients na bedridden, wherein there is already deterioration of your muscle mass, then it is expected that their level of your CK, baseline normal level of their CK value will be low. So that ends our CK discussion. Now let's proceed with your lactate dehydrogenase. Later on, we will discuss about the package insert of your CK that we actually perform in the laboratory. For your lactate dehydrogenase, we will be discussing about the properties, the tissue source, the different diagnostic significance, the assays itself, and the sources of error. Your lactate dehydrogenase has an enzyme nomenclature of EC11127. It is also termed as your L-lactate, NOD+, oxidoreductase. NOD+, pag sinabing NOD+, this is a oxidized form. Not oxidized nicotinamide adenine dinucleotide oxidoreductase. It catalyzes the interconversion of your lactic and your pyruvic acids and hydrogen transfer enzyme that uses the coenzyme NOD+. So in short, dalawang action lamang ang lactate dehydrogenase. It's either convert your lactic to pyruvic or your lactate to pyruvate or pyruvate to lactate. What else? Since its other name is oxidoreductase, its action is either to oxidize or to reduce your coenzyme NOD+. So let's take a look at the principle. Again, this is around 128 kilodalton and has 4 subunit. H or heart, either H or M. H stands for the heart, M stands for the muscle. In 5 arrangement, each is around 32 kilodalton. So for the reaction, as what I said, interconversion of your lactate to pyruvate or pyruvate to lactate. Either way, kaya nga dalawang arrow nito, it's either forward or backward reaction. And anong isang function ng ating lactate dehydrogenase? Oxidoreductase. It could either oxidize or reduce your NOD+. It is, kung once oxidize ito, it will be reduced into nicotinamide dinucleotide, releasing your hydrogen, or it could oxidize your NOD-H, producing now your oxidized nicotinamide adenine dinucleotide. So, dalawa lang action yan sa conversion of your lactate to pyruvate or pyruvate to lactate and the oxidoreductases. Oxido or reductases because it can oxidize or reduce your coenzyme NOD+. So, what are the tissue sources? It is widely distributed in the body. It has higher activity in your heart, liver, skeletal muscle, kidney, and also your erythrocytes. And lesser amount, it could be detected in your lung, smooth muscle, and in your brain. So the isoenzyme determination has more significance than the total LD. Again, it has 4 subunits, either heart or M muscle in 5 arrangement. Your LD1 is the fastest. So these are now the different isoenzyme. We have LD1, which is HHHH, LD2, HHHM, LD3, HHMM, LD4, isang H, tatlong M, LD5, M lahat. As what you can see, di ba? Sabi natin, pag H, heart, pag M, muscle. Heart and muscle, it's already a combination of the different tissue. So your LD1 can be found into your heart and red blood cells. Remember that. Your LD4 is specific into your liver. Your LD5 is specific to skeletal muscle. Your LD2 could also be located in your heart and your red blood cells. So as what you can see, your LD1 and LD2 would be located in your heart and your red blood cells. How about your LD3? Can be located in your lung, lymphocyte, spleen, and your pancreas. So basing on the tissue location of the following of the different isoenzyme, you can identify what are the possible disorder. Kaya nga, since heart, more of your myocardial infarction. Since RBC, could also detect your hemolytic anemia. If it's LD4 liver, so we expect that it has something to do with hepatic injury or inflammation. So in short, the location of this isoenzyme will help us identify what would be the possible disorder. That is why kaya nga sinabi natin kanina, isoenzyme determination has more significance than total LD. Kasi nga, ang isoenzyme, different isoenzyme, will give us clue of what different disorder can be identified. It's easier for us na ma-detect kasi nga mas specific siya compared kung total LD ang ating ipapatest. Kung total LD, of course, we will think of all of this disorder. Unlike kung specific isoenzyme, we can now narrow down our differential diagnosis. So in our normal sera, the major isoenzyme is your LD2. So again, in a normal healthy individual, your normal sera is your LD2. Cardiac tissues and red blood cells have LD1 greater than LD2. So therefore, in certain conditions, pag merong patient myocardial infarction or necrosis, what will happen is that your LD1 becomes higher compared to your LD2. Ang tinatawag natin dito is your LD flip pattern. Again, the major isoenzyme of a normal individual is LD2. Pero pag ang individual will have myocardial infarction or any disorder that has something to do with cardiac tissue and red blood cells, there will be a LD flip pattern wherein LD1 becomes greater compared to LD2. As what you can see, the different isoenzymes, your LD1 is around 14 to 26%. Your LD2 is around 29 to 39%. LD3, 4, and 5. So based on this diagram, we can say that your LD2 is the major isoenzyme. Kaya in a normal healthy individual, LD2 is more prominent than the rest of the isoenzyme. Ang pinakamaliit is your LD5. Pag you have a myocardial infarction, there will be a flip pattern wherein your LD1 becomes higher than your LD2. Remember that. So elevated in various disorders, if they have cardiac, hepatic, skeletal muscle, renal, hematologic, and even your neoplastic. However, these are very unspecific, meaning we cannot really identify if we check for your LDH, we cannot really say that the patient has a specific hepatic, skeletal, renal, hematologic. We have to correlate that again with different diagnostics because your LDH is located in a different organ system. Tingnan natin again, very prominent sa other organ system. Pwede sa liver, sa pancreas, sa spleen. That's why your LD is really not specific. So again, the normal one, you have LD2 is greater than LD1, then followed by 3, 4, and 5. If we have LD flip pattern in certain conditions such as acute myocardial infarction, intravascular hemolysis, the serum levels of LD1 will increase to a point at which they are present in greater concentration than your LD2. This flip pattern is suggestive of acute myocardial infarction. However, LD is not specific to cardiac tissue and it's not preferred marker of your diagnosis for your AMI. Kasi nga, your LD is located in various tissues. So your LD flip pattern, once your LD1 and LD2 ratio is greater than 1, that's also an indicative of hemolyzed sample. That is why you need to recollect again blood sample. LD3, pulmonary involvement and even your carcinoma. LD4 and LD5, more predominant in the liver and your skeletal muscle. LD5 is greatest clinical significance is in your intrahepatic disorders and again, your muscular dystrophies. Is there a 6 isoenzyme? Yes, we have a 6 isoenzyme. The 6 isoenzyme which is cathodic to your LD5. LD6 which is your alcohol dehydrogenase and it's correlated with atherosclerotic cardiovascular failure. It also signifies grave prognosis and impending death. Your LD5 is elevated concurrently with LD6, so liver injury secondary to severe circulatory insufficiency. So one of the major purpose of your LD is really to detect your myocardial infarction. However, your LD is not specific, but still we can have an idea about however, we can correlate the levels of your LD to the different enzymes. For MI, your lactate dehydrogenase will rise within 12 to 24 hours after the onset. It will peak around 48 to 72 hours and remains elevated to 10 days. Remember your CK? Your CK will rise again at approximately 4 to 8 hours, right? And also peak around 24 to 48 hours. However, your CKMB will be normal after 2 to 3 days. Unlike your lactate dehydrogenase, it becomes elevated even until 10 days. So we have a very good diagram here that differentiate your CK, AST, and LD in terms of the effect of your myocardial infarction. But before that, I'll give you an overview of what is myocardial infarction. Kasi nga, paulit-ulit natin dinidiscuss ang MI. At least to give you an overview of what is MI. So your MI, myocardial infarction, is actually under the spectrum of acute coronary syndrome. Myocardial infarction. Ano ba ang myocardial infarction? What is the pathology of your myocardial infarction? In myocardial infarction, the problem is in your coronary. Diba? The coronary is the blood supply of your heart. So, this is a blood vessel that supplies your heart. In short, it will deliver oxygen to your heart. Even though the heart that is one delivering oxygen towards the body, of course, the heart itself needs a oxygen supply, and that oxygen supply comes from your coronary arteries. So your acute coronary syndrome is actually a spectrum of disorder. It could be unstable angina, non-Stemi. Pag tinabi natin non-Stemi, non-ST elevation myocardial infarction. Pag sinabi naming Stemi, we have ST elevation myocardial infarction. Paano namin ma-differentiate if it's non-ST elevation versus ST elevation? We request for ECG. So basically, it's not just blood tests. We have to correlate and check the ECG findings of our patient. Pag malaman namin na ST or non-ST, then we can identify. We can identify now. How can we differentiate unstable angina from non-STEMI? Kasi nga, your unstable angina and non-STEMI, usually they manifest the same. To differentiate your unstable angina and your non-STEMI, we request for your troponins. Now remember your troponins, that's why your troponins are very specific and sensitive marker for your myocardial infarction. When there is a normal levels of your troponin, then we can say that it is unstable angina. But when it is elevated, we can say that it is non-STEMI. So check natin, how about sa STEMI, doc? What will happen to your biomarkers? Of course, for your STEMI, we have a very elevated troponin, unlike to your non-STEMI. Pero madi-differentiate na naman natin ng non-STEMI versus your STEMI because of the ECG itself. Pag ST elevation, that's your STEMI. And also, in your biomarkers, your troponins is very elevated. In terms of its pathology, tingnan natin. In your unstable angina and your non-STEMI, ano nangyayari? There is this your coronary, cross-section of your coronary blood vessel. There is a plaque and there is a thrombus. This plaque and thrombus cause now a blockage of your blood vessel. So, konti na lang. Kita nyo ito? This one is the only lumen that is not blocked by your plaque and thrombus. So in short, there will be a decreased oxygen supply towards your heart. How about your STEMI? Your STEMI is much more complicated compared to your unstable angina and your non-STEMI. Why? Check this out. Your coronary arteries, this is a cross-section of your coronary arteries, the plaque and your thrombus totally block your coronary arteries. Therefore, if it completely blocks your coronary arteries, there will be 0% oxygen level to the heart. That is why your STEMI is more worse than your unstable angina and your non-STEMI. So how do we manage our patient? The management will be different. That's why you need to have a clinical eye. Dapat pagkita mo lang, check mo na agad ECG, clinical finding ng patient. You already request for your troponins. Dapat mabilisan kasi nga your STEMI is more complicated than your non-STEMI. The management would also be different. In patients with myocardial infarction, the common manifestation will be chest tightness. They will feel heaviness in their chest around the heart area. So how do we differentiate also if it's MI versus non-MI pathology condition? We ask our patient, ma'am, asa ang dapit ang sakit? When the patient says na, doc, dito po sakit banda, when the patient can pinpoint the problem, then the probability that it is an MI is very low. Because in myocardial infarction, you cannot actually identify the pain because the pain is actually around your chest. There is chest tightness and it could radiate towards the back and into your forearm and even to the back part and even to your shoulder. So that's how painful your STEMI. That's why you have to be very fast, very efficient, to have a good clinical eye. Kasi nga, anong mangyari? 0% na oxygen sa heart mo. What will happen? Then you will undergo heart failure. There will be problem now in your heart and the patient may go to arrest. So at least now you have an overview of how we diagnose patient with myocardial infarction. It is not only troponins actually. We also request this different enzymes. Dito nalalabas yung different enzymes. Your CK, your AST, and your LD. But again, what is the most sensitive marker for your MI? It is your troponin I and your troponin T. But in terms of the enzymes, which is more specific, it is your CKMB rather than versus your AST and LD. Your CKMB will tend to rise. If you have acute myocardial infarction, your CKMB will tend to rise. Ano nga yun? 4 to 8 hours aakit na, and it will peak around 24 hours. Your AST will peak after your CK, while your LD will be the one that peaks last or increased last, usually around 12 hours. What can you also observe? Your CKMB will go back to normal around 2 to 3 days. How about your LD? Your LD will go back to normal around after 10 days kasi nga magpipeak siya around 10 days. How about AST? Will go back to normal around 4 to 5 days. So in short, your CKMB increase first and go back to normal. In patients with myocardial infarction, with patients with acute myocardial infarction, hindi lang yan one time mag-EMI. Most probably, the patient will undergo reinfarction. That's why patients with MI, we tend to put them on the intensive care unit kasi nga there is a big chance that this patient will undergo reinfarction. Now question, among these enzymes, sino kaya ang best for checking in terms of reinfarction? Ano kaya ang pinakamagandang i-request natin if the patient is having reinfarction? Sige, sabihin natin at 4th day, the patient underwent another myocardial infarction, a new onset of myocardial infarction. Among these tests, which do you think will be requested? It is your CKMB. Bakit? Remember, your CKMB becomes normal after 2 to 3 days. After 2 to 3 days, unlike your AST and LD, it will be prolonged to several days. That's why we cannot identify whether the patient is already undergoing another form of infarction. If CKMB is increased after 2 to 3 days, then that's a good indication that the patient is having reinfarction. So I guess you have already the idea of correlating now your CKMB, your AST, and your LD. Pero guys, in reality, what we really check is your ECG, the clinical manifestation of the patient, the levels of your TROP-I, and most specifically, if you want to check for reinfarction, anong chine-check namin is your CKMB. We do not check now, hindi na namin ni-request ang LD at saka AST because these two enzymes are very non-specific. Your LD can be seen in different disorder as well as your AST. Remember, your AST is a liver enzyme. That's why we only request for your CKMB, your TROP-T, and TROP-I. And a correlation between your ECG, between the clinical manifestation of the patient, the physical findings of the patient. And with that, with all of these things, we should be able to identify the proper diagnosis and the proper management of our patient. So now let's compare again your CKMB to your troponins. As what you can see, your troponins here, mas nauuna talaga siya sa ating CKMB. However, your troponins remain high after several days. Kaya nga, question, between troponin and CKMB, which do you think is better for reinfarction, meaning new onset of acute myocardial infarction? Anong ititest natin, CKMB or troponin? Again, we will still choose for CKMB kasi nga bumabalik siya agad to normal after 2 to 3 days. Unlike your troponins, it will take several days before it reaches its normal level. But what is more specific and sensitive to your acute myocardial infarction, it is your troponins. Okay, I guess that's clear. Now for the assays enzyme activity of your LD, we'll do your electrophoresis. We can also identify the different atypical bonds. Meron din tayong ma-identify na atypical bonds. These atypical bonds are LDs that is complexed with your immunoglobulin. What are the two immunoglobulins? Either IgA and your IgG, similar with your CK. So your LD, IgA or IgG is between LD3 and LD4, but these are not associated with clinical abnormalities. Other tests, you can do immuno inhibition, chemical inhibition, and the different substrate affinity. Differences in substrate affinity, your substrate will be your alpha hydroxybutyrate with increased affinity with your H subunit than your M subunit. Your alpha hydroxybutyrate dehydrogenase activity considered as a representative of LD1 activity but not specific. Why do you think not specific for LD1? Because your LD2, LD3, and your LD4 can also contain your H subunit, meaning it is not specific for LD1 only. It's a good representative but not specific. So this is now the principle of your LD test. Your substrate, your alpha ketobutyrate, using your nod H and your H with the action of this enzyme, yielding now your alpha hydroxybutyrate. So the rate of the reverse reaction is approximately 3 times faster but more susceptible to your substrate exhaustion and loss of linearity. So in terms of the test, we can also do your forward test and your backward test. For the forward test, we actually use your Walker's test using this pH 8.3 to 8.9, while your backwards test using also still a slightly basic test, your Roblowski Laddu. I don't know how to pronounce that. It's around 7.1 to 7.3. Just remember, forward, Walker, backward, your this test. I don't know how to pronounce that. So, again, this is the principle for your lactate dehydrogenase. Ano nga yun? Dalawang action lang yung lactate dehydrogenase mo. Ano yung dalawang action? Again, interconversion between your lactate to pyruvate or pyruvate to lactate. Another one, your oxidoreductases. Oxido, it could oxidize or reduce your coenzyme NOD+. What happens? Your lactate will be converted to pyruvate, or your oxidized nicotinamide adenine dinucleotide can be reduced into reduced nicotinamide adenine dinucleotide and producing your hydrogen ion. So in terms of the sources of assay error, RBC contains LD concentration 100 to 150 times than found in the serum. Your LD activity is unstable in serum regardless of the temperature and should be stored at room temp and analyzed within 48 hours. Your LD5 is most labile. Loss of the activity is more quickly at 4 degrees Celsius than room temp. Your LD isoenzyme analysis should also be stored at room temp and analyzed within 24 hours of collection. But the important thing here is about your hemolyzed sample. If you have a hemolyzed sample, then that's going to be a problem because it will yield a false positive or increased level of your LDH. Remember, your LD concentration is 100 to 150 times higher found in your serum. So before we end, I guess we will have a discussion of the two laboratory inserts of your CK and LD. In the laboratory insert of your CK and LD, we will discuss how to solve and compute the values of your CK and LD using your spectrophotometer.